Righty. Alrighty, so we're going to get started. Again, if you have not done so already, please be sure that you fill out the pre-session survey if you would like a certificate of training or a CNE credit for this course, Preventing Healthcare-Associated Infections, Methicillin-Resistant Staphylococcus aureus. I'll have Maddie, put it in the chat one more time as you all kind of trickle in. And the next slide, we're just going to go over all of our requirements anyways for our continuing education. So go ahead and keep filling it out if you are. So here's the continuing education criteria for those of you who are attending and would like to receive CNE credit. This session is approved as one contact hour. This nursing continuing professional development activity is approved by the Northeast Multi-State Division Education Unit and accredited approver by the American Nurses Credentialing Center's Commission on Accreditation. To receive your certificate of training, CE Dental IPC or CEEMS, you will need to complete the following: the pre-session survey, attend the entire webinar, and then the post-session survey. To receive your CNE credit, you will need to complete the pre-session survey, attend the entire webinar, the post-session survey, and then the post-session quiz that will be emailed to you tomorrow. Before we move on to the agenda, I did want to take a moment to introduce myself to those of you who are new to our webinars. My name is Allison Thurber. I have been a nurse at the Rhode Island Department of Health in the Center for Acute Infectious Disease Epidemiology for the past 7 years. Part of my assignment includes Project Firstline Rhode Island, and this is education as an infection prevention training liaison. And I truly enjoy being with you here and, love refreshing and giving important infection control and prevention topics and discuss with you and have that back and forth conversation that truly needs to be had for infection control and prevention. And today, as you may have seen on the previous slide, we will be discussing methicillin-resistant Staphylococcus aureus. So our agenda for today includes the welcomes and introductions. And after the slide, we'll go over learning objectives. We'll then talk about what is MRSA and how does it impact our healthcare system, MRSA transmission, MRSA infection prevention and control. We'll go over a case scenario that kind of summarizes everything that we've reviewed in this course. We'll go over key takeaways, end of session feedback, and then we'll have our Q&A. So if you have any questions, please be sure that you put the questions in the Q&A box. It'll either be at the top control center or bottom control center of your screen, depending on your Zoom preference. So put your Q&A questions in there. We'll answer them at the end. But if throughout the webinar you need to reach us or are responding to a colleague or are interacting with a question that I'm asking you, please put that in the chat box. And again, that's still in the top or bottom drop down on your screen. So learning objectives today are to understand the impact of MRSA infections in healthcare, to know the different ways MRSA can spread in the healthcare setting, and to identify infection control actions to prevent MRSA infection. So let's dive right into our MRSA content. And we'll start with what is MRSA, MRSA, Methicillin-Resistant Staphylococcus aureus. Staphylococcus aureus, also known as staph, is a bacterium commonly found on the skin and in the nose of about 30% of individuals. Most of the time, staph does not cause any harm, but it can sometimes cause infections. And in healthcare settings, infections can lead to serious or fatal outcomes. MRSA, again, is short for Methicillin-Resistant Staphylococcus aureus, also known as MRSA or MRSA. Some types of Staphylococcus aureus are resistant to common antibiotic treatments. MRSA is considered drug resistant and is resistant to several kinds of antibiotics: methicillin, oxacillin, amoxicillin, and penicillin. CDC estimates that MRSA is responsible for more than 70,000 severe infections and 9,000 deaths per year. So a little history for you. In 1881, Staph aureus was given its name when it was isolated from a wound. Prior to the availability of penicillin, the fatality rate was 90%. Penicillin soon became useless when Staph aureus became resistant. Then another antibiotic with the name of methicillin was discovered in 1950, and that was effective against Staph aureus for a long time, but eventually also gained resistance. The resistance to this antibiotic was reported at an increased percentage, which then gave it the name methicillin-resistant Staph aureus, MRSA. So MRSA can cause different types of infections, including skin and soft tissue infections, surgical site infections, pneumonias, bloodstream infections, and sepsis. The symptoms of MRSA depend on the part of the body that is infected. Broken skin, such as scrapes or cuts, is often the site of a MRSA infection. So for that reason, we will go over these symptoms in a little bit more detail. So most infections appear as a bump or infected area on the skin that might be red, swollen, painful, warm to the touch, full of pus or other drainage, or accompanied by a fever. Preventing MRSA infection is important in itself, particularly because of growing antibiotic resistance. However, preventing MRSA infections from progressing to bacteremia, which is presence of the bacteria in the blood, is even more important because mortality among those individuals with MRSA bacteremia ranges from 15 to 50%. Usually, MRSA bacteremia begins with an initial MRSA infection, like a surgical site wound, for example, and then that progresses to bacteremia. So the primary sites of infection usually include vascular catheter-related infections, skin and soft tissue infections, pneumonias, surgical site infections, and endocarditis. So while anyone can get MRSA, there are some people that are at higher risk for infection, and you're at higher risk for infection from MRSA when you have had surgery, have had medical devices inserted in your body, use needles to inject drugs, have previous MRSA colonization, are older and immunocompromised, or have a history of extensive antibiotic use. So understanding MRSA colonization is crucial for preventing infections and controlling its spread, especially in vulnerable populations. By adhering to proper hygiene practices and being aware of the risks, individuals can help themselves and others from MRSA-related complications. But to understand MRSA, it's important to know that infection can be either colonized or active. But in either case, it can be spread. So a few more numbers for you all. About 1/3 of people, 33%, carry Staph aureus bacteria in their nose. And this is the main site of colonization, usually without showing any illness. But 2 in 100 people, 2%, carry MRSA. Colonization is having the presence of MRSA infection, but not having illness. And again, both require special considerations when caring for patients to help prevent the spread of disease, like following transmission-based precautions, for one example. So MRSA can be found in healthcare environments and in the community. Healthcare-associated, HA, sometimes abbreviated, means that the MRSA infection developed in the healthcare setting, usually in a hospital. In healthcare settings, MRSA can cause severe problems, including bloodstream infections, pneumonia, surgical site infections, sepsis, and sometimes death. Community acquired, also abbreviated as CA, is common in the community and otherwise healthy population who have not been hospitalized or had a medical procedure recently or within the past year. And this is transmitted person to person in the community. So how does MRSA spread from one person to another person? So first, we have a person's own MRSA colonization that can lead to invasive disease. Then we have surgical procedures. Examples include using improperly disinfected, sterilized instruments, lack of or ineffective surgical hand hygiene technique, poor wound care, things like that. In healthcare settings, MRSA usually spreads through direct contact when an infected wound or from contaminated hands. It can also spread from the environmental reservoirs such as bedding, doors, equipment. So here you can see the person with MRSA. I'm going to get my little laser pointer. Okay, so here you see you're starting with a person who has MRSA. They're symptomatic, they're asymptomatic, it doesn't matter. They have MRSA in this situation, and they are the reservoir. The pathway to the next person is via indirect or direct to the environment or to another person. And this allows the germs to move. Other patients in the hospital may be immunocompromised, and then this makes them the perfect new host if the germs are able to travel to them. All right. So then this image here you can see in front of you is a visual depicting how individual factors and facility factors can affect MRSA infection. So some individual factors that we are unable to prevent are age, comorbidities, and someone's immune system, right? As healthcare workers, we're unable to alter that in any way. However, some individual factors like antibiotic use, we can try and help prevent along with facility level factors. The facility level factors are here at the bottom. Facility level factors can also be known as infection prevention and control. So these factors include hand washing, PPE use, cleaning and disinfection, isolation, crowding, nurse-patient ratios, patient isolation, healthcare worker compliance. Again, these are all infection prevention control actions, and we'll touch on all of these throughout this presentation. So now that we have the general understanding for what MRSA is, we're going to talk about how we as healthcare workers can help prevent healthcare-associated infections in our daily practice. So how can we decrease the risk to our patients from MRSA? Each of the next concepts listed we'll go over in more detail. We're just going to list them here briefly. So we have prevent direct transmission, decontaminate the environment and instruments, prevent procedure infections, rapid recognition and decolonization, and antimicrobial stewardship. So first we have prevent direct transmission, which also kind of opens up a segue of more topics. So there's a few ways healthcare workers can prevent direct transmission from one person to another. And this includes effective hand hygiene, initiating and maintaining isolation of the patient, adhering to transmission-based precautions, teaching and performing clean wound care, and patient education. So the practice of hand washing or application of an alcohol-based hand sanitizer must be conducted after caring for a patient with MRSA. Hands must be cleaned immediately following removal of gloves with an alcohol-based hand sanitizer or soap and water. Gloves must be discarded prior to leaving the room, and any sort of hand moisturizers or lotions should be compatible with cleansing products and the type of glove material that's being utilized in the facility. So whether in a long-term care or acute care facility, a private room should be utilized for all patients who are infected or colonized with MRSA. If a private room is unavailable, then it would be appropriate to cohort patients who are positive with MRSA together in a room. In the hospital, patients are recommended to be restricted to the room, except when in need of diagnostic or therapeutic services. When it's necessary to leave the room, patients must have freshly laundered clothing and must have practiced hand hygiene prior to coming out of the room. In long-term care facilities, room restriction is not recommended. Quality of life plays a large role in the health of residents, and in a long-term care facility, that's their home. So residents with MRSA may use common areas and group dining facilities if the following criteria can be met. Secretions and excretions containing MRSA are covered and contained. The resident practices hand hygiene before leaving the room, and the resident is wearing clean clothes. So in both acute care facilities and long-term care facilities, we're going to employ the same precautions. Transmission-based precautions are key to controlling MRSA infection and preventing further spread. MRSA is predominantly spread via touch. Therefore, healthcare staff should adhere to contact precautions. That means gowns and gloves when caring for patients, whether they are active or colonized. This also includes assessing the need for additional precautions like...
Are you wasting the air fryer? You want it? Yes, it's kind of. There's something good.
Okay, sorry, I think someone was accidentally unmuted. This also includes assessing the need for additional precautions like a face shield if you are suctioning a patient with MRSA in the nares, or something that's specific to the task or potential infection risk. So in the hospital, masks are also recommended when caring for patients with MRSA in the nares or the sputum, and those that are requiring ventilation assistance. Staff should use dedicated patient care equipment like blood pressure cuffs or stethoscopes, and single-use disposable items like a single patient digital thermometer whenever possible. It is recommended visitors wear gloves when visiting and a gown if they're having close contact with a patient or are helping to perform care. So I will put in a little plug that Project Firstline Rhode Island does have a webinar that discusses donning and doffing in depth if you, staff, colleagues, are in search of further personal protective equipment education. It is recorded and up on our Project Firstline Rhode Island website for self-paced learning if you're interested. So we'll just go over donning and doffing for MRSA specifically briefly. So for MRSA, contact precautions are recommended, along with the mask during certain procedures that may put the healthcare worker at risk for respiratory splashes, sprays, or aerosolization. So we have donning and doffing. Donning means to put on and use PPE properly to achieve the intended protection and maximize the risk of exposure. And doffing means removing PPE in a way that avoids self-contamination. So when we are getting ready to enter a room with a patient who does have a MRSA infection, you want to make sure that you secure your hair, any loose clothing prior to donning. Then you'll perform hand hygiene with an alcohol-based hand sanitizer or soap and water. Then you will don your gown. Fully cover your torso from your neck to your knees, arms to the end of your wrists, and then wrap around the back. Fasten in the back of your neck and your waist. Then you will don gloves. Extend your gloves to cover the wrists of the gowns so that there are no exposed areas. So then when you're doffing your PPE, you will first doff your gloves. The outside of your gloves are contaminated, or most likely to be contaminated. So using a gloved hand, you will grasp the palm area of your other gloved hand and peel off your first glove. Then you'll hold the removed glove in your hand that's still gloved. Slide your fingers of your ungloved hand under the remaining glove at the wrist, because underneath that glove that's touching your wrist should ideally be not contaminated. You'll peel off the second glove over that first glove and discard them in a waste container. Then next you will doff your gown. Your gown front and sleeves are contaminated. So you would unfasten gown ties, taking care that the sleeves don't contact your body when reaching for those ties. You'll pull away your gown from the neck and the shoulders, touching the inside of your gown only. Turn your gown inside out or fold it and roll it into a bundle, and then discard it into the waste container. You'll make sure that you wash your hands with soap and water or an alcohol-based hand sanitizer. And then you want to make sure that you remove all your PPE and discard it prior to exiting the patient room. So another prevention method that falls under direct person-to-person transmission is wound care. Wounds with MRSA prolong healing time. Prolonged duration of wound infection will translate into the need for more facility-based care. It will translate into an increased cost of medical care, and most importantly, a higher morbidity rate. MRSA wound colonization can result in a surface infection leading to the bloodstream, as well as various body organs and tissue systems. Clean and consistent, educated wound care is critical to decreasing MRSA infections in the wounds and increased infection severity. Infected wounds filled with purulent drainage must be drained, cleaned, and properly dressed to improve wound healing while limiting bacterial proliferation. Staff should have adequate and regular wound care education, as well as the tools to educate patients and their families about the importance of clean, appropriate wound care to prevent infection once discharged out of that facility. And this leads us to patient education, our last direct transmission prevention method. So patient education helps us to reduce MRSA by teaching core IPC actions. Patient education includes hand hygiene. It also includes teaching the patient about early signs and symptoms of sepsis, like clammy or sweaty skin, confusion or disorientation, extreme pain or discomfort, fever, shivering or feeling very cold, high heart rates or a weak pulse, shortness of breath. And lastly, wound care should be included in our patient education. Wound care and patient education should include keeping cuts and scrapes clean and covered with bandages or until the dressings until it's healed. To follow your healthcare provider's instructions about proper care of the wound. It's important to know that pus from infected wounds can contain MRSA. So use barriers like a towel or clothing between your skin and shared surfaces, and do not pick or pop at any sores or open areas. Our next infection prevention method is disinfecting the environment and instruments. MRSA can survive on some surfaces for hours, days, or weeks. And this includes on towels, razors, furniture, medical devices, any other similar surfaces. Use dedicated patient equipment when possible, but if not, it's important to properly disinfect all the other equipment in between patient use. Even when a surface appears clean, it's important to know that it can still have germs on it. So it's important to use an EPA-approved disinfectant from List H, and that will ensure that the product is effective against MRSA. So I will have my colleague, Maddie, put that in the chat for you so that you have that link if you need to check any products. So Staphylococcus aureus is the leading causative agent of surgical site infections. And for that reason, taking measures to prevent surgical site infections is key to preventing MRSA infections. Staph aureus makes up 17.5% of overall surgical infections, 38.6% of orthopedic and spinal infections, and 27% of cardiac infections. Surgical site infections due to MRSA lead to higher morbidity and mortality. So again, infection prevention and control practices are important to prevent infection through surgical procedures. This includes at home, before the procedure, pre-op, at the hospital, awaiting the procedure, during the procedure, and post-op after the hospital, whether it be in the hospital or after the procedure, whether it be in the hospital or at home. So there's 4 key strategies to prevent MRSA and target surgical site infections, and those include nasal decolonization, preoperative chlorhexidine gluconate, CHG skin antisepsis, antimicrobial prophylaxis, and evidence-based infection prevention. So the first that we named is nasal decolonization. Nasal mupirocin is recommended 5 days pre-op or some sort of iodine-based product. Next, there's pre-op CHD skin antisepsis. CHD skin antisepsis decreases microbial burden on skin. It's recommended 5 days pre-op as well as the night before and the morning of surgery. There's antimicrobial prophylaxis. That's pre-op antibiotics for all surgical patients to maintain antimicrobial drug levels during surgery. Of note, cefazolin is usually the most common antibiotic used. The right drug dose and timing target relevant bacteria and minimize the adverse effects. And other evidence-based infection prevention strategies include hand hygiene, surgical scrub, skin prep for surgery, hair removal, glycemic control, normothermia, and reduced OR traffic, staff coming in and out of that OR exposing the patient to more increased risk of infection. All right, so next is recognition and decolonization of patients. So consider active surveillance testing for MRSA on admission to acute care facilities. This will help detect colonized patients who may not otherwise show signs or symptoms of MRSA. Screening could be limited to high-risk patients, for example, ones that just came from a healthcare facility and had a healthcare exposure, or admission to high-risk settings like an ICU, for example. Active surveillance testing should be combined with decolonization or pathogen reduction strategies as described above for high-risk patients. In all settings, acute and long-term, consider all infected wounds with drainage to be potentially infected with MRSA. In other words, test them and follow all precautions necessary for MRSA until proven otherwise. Decolonization is an infection prevention practice that removes germs from the skin. It includes antiseptic bathing routine using a special soap on the skin and applying an antiseptic or antibiotic product in the nose. Decolonization can keep patients from developing an infection themselves or passing the germs on to others. And then last year we have antibiotic stewardship. So antibiotic stewardship employs evidence-based decision-making to optimize appropriate antibiotic use. Antibiotic stewardship ensures that every patient gets an antibiotic only when needed, the right agent, the right dose, and for the right duration. So we can't argue that antibiotics are life-saving drugs, but a significant amount of antibiotics in the hospital setting, approximately 30% of them to 50% of them, are prescribed inappropriately. And this leads to adverse events for patients related to antibiotic therapy. Inappropriate antibiotic use also heightens the risk of multi-drug resistant organisms, also known as MDROs, such as MRSA that we're talking about today. Antibiotic stewardship employs evidence-based decision-making to optimize appropriate antibiotic use. Hospital antibiotic stewardship programs can increase infection cure rates while reducing treatment failures, C. diff infections, adverse effects, antibiotic resistance, and hospital cost and length of stays. So in front of you is an image used to guide providers in prescribing and continuing antibiotics. So some questions as a prescriber you may want to reflect on include, does my patient have an infection that requires antibiotics? Have I ordered appropriate cultures before starting my antibiotics? What empiric therapy should I initiate? A day or more has passed. Can I stop antibiotics? Or can I narrow therapy or change from IV to oral therapy? And what duration of antibiotic therapy is needed for my patient's diagnosis? Again, just some thoughtful questions to help you guide and constantly keep thinking and reevaluating antibiotic use. Okay, so in the next portion of this webinar, we'll go through a case study together to apply some of the concepts we've learned this session. So I'm just going to start by reading the case study. A new nurse, Sarah, is starting her shift on the medical surgical unit at the hospital. She is preparing to care for Mr. Jones, a patient recently admitted with pneumonia who was also found to be colonized with methicillin-resistant Staphylococcus aureus, MRSA. Excuse me. Mr. Jones fell at home after a change in mental status and has sustained a wound to his knee that was cleaned and sutured in the ER. So just first quick question I'm going to ask you, and you can put your answer in the chat if you feel comfortable, is how does Sarah know that Mr. Jones has MRSA in his NARES? Pull up the chat box here. After everything we've discussed, how does Sarah, the nurse, know that Mr. Jones has MRSA? What kind of testing would you be looking at? Perfect. Okay. Yeah. So you did your screening swab. So the acute care facility, it's recommended that acute care facilities do screening swabs on anyone that comes in that's considered high risk. So here, Mr. Jones had a screening swab done and it came back positive for MRSA in his NARES. Perfect. All right. So the next part of this interactive case study, we have 5 numbers at the bottom here, and each of these numbers represent an infection prevention and control action pertinent to Mr. Jones and his situation. So upon notification of Mr. Jones' diagnosis, what are some infection prevention and control steps that Sarah, his nurse, should take? And again, these are kind of like the 5 top ones that we've covered. All right, so it looks like, let's see first. Someone said contact precautions. Let's take a look. Perfect. So personal protective equipment. Sarah explains to Mr. Jones that his family that because of MRSA colonization, he'll be on contact precautions during his stay. And it looks like you guys are one step ahead of me because I already see the answer in the chat. What PPE would Sarah put on? Gown and gloves. Perfect. Always a little tricky navigating the chat and the presentation, so sorry if this gets a little clunky. All right, so back to the case study. So we have PPE. It looks like someone else wrote dedicated equipment in patient room if possible. So correct. That applies to number 4, which is limiting patient movement and transport and isolation. So Sarah explains to Mr. Jones that his movements outside the room may be limited to essential purposes only to prevent MRSA transmission based on the facility's protocol. She ensures that if Mr. Jones needs to be transported, appropriate precautions are taken to prevent the risk of spreading MRSA to others. Great. So there's a few more. Someone else put education. Yes. So our infection prevention number 5 is education. Sarah explains all changes to the patient care plan to Mr. Jones. Sarah continues with patient education, being sure Mr. Jones understands his risks and signs and symptoms of infection, understands cleaned wound care, and implications of infection control within the hospital setting. All right, so there are 2 more that we have not covered yet. Anyone has any guesses as to what those 2 are? We covered PPE, limiting movement and isolation, and patient education. What are 2 other really critical parts of infection control and prevention with MRSA? Bingo. Somebody said cleaning and disinfection. There's one of them. Oh, sorry, this PowerPoint has a mind of its own. Environmental cleaning and disinfection. Sarah points out high-touch surfaces in the room, bed rails, overbed tables, call buttons, and explains that these need frequent cleaning and disinfection to minimize MRSA transmission. A designated environmental services staff member uses an EPA-registered disinfectant to clean and disinfect high-touch surfaces, emphasizing the importance of following the product's instructions for concentration and contact time. And it looks like you guys got that last one too, which is hand hygiene. It's always first in every IPC question. So hand hygiene. Sarah cleans her hands before entering Mr. Jones' room. And then she explains to him that MRSA is a germ resistant to some antibiotics and that proper hand hygiene helps prevent its spread. Sarah demonstrates the proper hand washing technique using soap and water or an alcohol-based hand rub, ensuring all surfaces of the hands are scrubbed vigorously for at least 15 to 20 seconds, especially after contact with patients or contaminated items. All right, so we got all 5 pertaining to Mr. Jones here. We have hand hygiene, PPE, environmental cleaning, limiting movement and isolation, and patient education. So let's go to our key takeaways now for today's session. So our key takeaways for today's session, MRSA can cause severe problems in healthcare facilities. MRSA can be resistant to several antibiotics, and MRSA prevention efforts can reduce infections. So I would like to remind everyone that there are a few requirements to receive your certificate of training. So in order to receive your certificate of training, you must complete our pre-session survey, participate in today's Zoom live session, and complete the post-session survey. A link for the post-session survey will be sent to you via email tomorrow, April 14th, and will be available until April 20th at midnight. Once you complete the requirements, our certificate of training will be emailed to you in PDF form on April 23rd. For EMS and dental providers, this can be used toward 1 hour of continuing education credit. Please be sure if you're looking to receive CNE credit that you complete the pre-session and the post-session survey, and also the post-session quiz that will be emailed to you tomorrow. This afternoon, the post-session training resources and PowerPoint will also be emailed to you. And I know I just kind of threw a lot at you. So if you have any questions or if something doesn't seem like it's going correctly, feel free to email us. So from exciting future training sessions that we have for you, first we have standard precautions and transmission-based precautions, TBP, EBP, in long-term care facilities. That's going to be on Monday, the 27th at noon, presented by my colleague Chinamso Ormegu. And then we'll have sepsis 1 and sepsis 2. They will be on Monday, May 4th at noon, and then Monday, May 18th at noon, presented by myself. And then we'll also have a webinar on measles in the healthcare settings in the Spanish language. That's not listed here on your screen. But that'll be on Thursday, May 14th at 5 p.m. and signups will become available on our live events page soon. And that will be presented by my colleague, Kelly Cotito. So if you did not enter your email earlier in the chat, please feel free to enter it now to be added to our distribution list of upcoming trainings. You can also email Project Firstline directly if you have any questions. You can also click on our live events link through our website, and Maddie will post that into the chat box as well. You can also follow Project Firstline on social media. Follow us on YouTube, X, which was Twitter, Facebook, Instagram, and LinkedIn. Here are the references for today's session. They're nearly impossible to see on the slide, but we will send you a copy of the slide deck. And if you could please take a moment and fill out our end of session feedback. Should have popped up on your screen. This helps us to improve all your future trainings to help suit your learning needs really quick. Go ahead and fill that out now. And then once I give you a moment for the end of session feedback, we'll move on to our Q&A. If you do have any questions that you did not put in the Q&A box as the session went along, please feel free to add them now so that we can take a look at them and answer them. I don't see any questions yet, but I'll invite Dr. Kearney to come on screen with me, our medical consultant for Project Firstline Rhode Island. in case we do have any questions, we can answer them together. I don't see anything. Let me just make sure there's nothing in the chat here. Oops. Doesn't look like we have anything. So if we don't have any questions, I will sign off, say goodbye. I hope that you all have an amazing end to the week. And I hope that we see you soon in some of our upcoming sessions. Thank you all.